Welcome to EASL Studio, your weekly hepatology broadcast news. In today's episode, we will see how to stop recurrent bleeding due to small intestinal angiodysplasia. I am Pierre-Emmanuel Rautou, Paris, France, and I am very happy today to be together with Professor Virginia Hernández-Gea from Barcelona, Spain, Professor Patrick Kamath from Mayo Clinic, Rochester, Minnesota, and Professor Wim Laleman from Leuven in Belgium. So typically, the situation is a patient having recurrent bleeding with no varices at endoscopy, and when a video capsule is performed, there are angiodysplasia. And I've got a question for you, Wim. What are these small intestinal angiodysplasia? How do they look like at endoscopy?
It's always a good thing, I think, Pierre-Emmanuel, to start with a definition, because there have been several definitions in literature, and I think everyone can think of one. In essence, these are abnormal, tortuous, dilated small vessels located in the mucosal or submucosal layer of the GI tract. We are really focusing now on small intestinal angiodysplasias, which are apparently, according to the existing literature, which unfortunately is not very extensive, is about 55 to 80% of all angiodysplasias. So these lesions also are, of course, held responsible for GI bleeding, but not like we know from variceal bleeding, ulcer bleeding. So they are supposed to account for about 5% of all GI bleeding. And like you told in your introductory case, most of them will be occult. But I think we should not forget that in about 10%, they can be overt and even be very firmly giving rise to even instability. But this is very exceptional. So you can have the whole spectrum.
Most often this is anemia, but in some cases it can be overt bleeding. Okay.
Yep. Okay. So I think your other question was about the endoscopic appearance.
Yes,
yeah,
exactly.
so that's also a challenge, because in contrast to varices, which are usually very clinically significant, or ulcers, which are very clear, these are very tiny lesions, so they can be very patchy. There are classifications which are usually related to the activity of the bleeding. So if at the video capsule the lesion is bleeding, well, they call it a type 1. If there is a stigmata of recent bleeding, so a clot or an ulcer or old blood, they call it type 2. Type 3 is a bit comparable to the cherry red spot we know from varices, and then the type 4 is the pale patchy lesion. So there is also a kind of hierarchy in bleeding tendency and also in terms of recurrency. So I think this is what we are dealing with.
And do you use in clinical practice this classification?
To be honest, this is not a very common problem. But of course, it gives you an idea on the probability that this is the culprit of the GI bleed, because usually this is a very a long journey of finding the place where it bleeds. Because I think we should need not forget that in fact most of these lesions, about 1/3, will have coexisting varices or other lesions if this is occurring in the context of cirrhosis, which usually is also part of a bigger entity called subpolar hypertensive enteropathy. So
that's very nice. It leads me to a question to Virginia, because often, Virginia, there are lesions in the stomach, lesions in the intestine. And do we need to treat all lesions, all small intestinal angiodysplasia? How do you see the strategy?
Well, I think that this is a very good question. You have a patient, and if you're performing the endoscopy because the patient is on refractory anemia and you are looking for something that may be the cause of the bleeding, then the situation is quite different than when you are just performing an endoscopy for some other reason and then you find them. And I think that, so this could give me a lot of tools to decide if I'm treating or not treating. I think that what being described, if the patient has anemia and you see a lesion that is bleeding in front of you, then it will facilitate more the things, and probably you will go for treatment. But for me, always the question is, okay, I see these lesions, the patient is not actively bleeding, I don't know if this is the cause or not. And then, is this a portal hypertensive enteropathy, or it's a real angiodysplasia? And I would like to go back to Wim to ask him, how do you distinguish these two lesions from an endoscopic point of view? Because then this will also help me a lot in deciding the management of the lesion.
It's a very difficult question because we do not have a standard definition. I mean, there's a lot of definitions. As I already told you, if you read different articles, everyone will come up with a slightly different definition. The one I personally favor is, in fact, the portal hypertensive enteropathy is a kind of a combination of where you have kind of inflammatory-like lesions like congestion, erythema, pseudopolyps, and then you have some vascular lesions like, for example, those angiodysplasia. So I think you should rather see this as a combined entity than a very distinctive single lesion. So this is rather how I see portal hypertensive enteropathy, which of course doesn't make it easy, because if you come from a portal hypertensive perspective in terms of treatment, well, if you think portal hypertensive or decreasing portal hypertension will solve everything, I'm not quite convinced that it will, but at least it will be part of the management. So this will rather be an all-in management than a focused management to one treatment.
So it leads me to a question to Patrick, because Patrick, you have a large experience on these difficult cases. So what is your global approach to these small intestinal angiodysplasia when you face such cases?
You know, following up on what Wim and Virginia said, in general, portal hypertensive enteropathy is far more common than ectasia. You know, so ectasia is not that common. Same in the stomach. Gastropathy, portal hypertensive related, is far more common than ectasia. So generally good. And like Wim said, the background helps you. You know, if the background shows you no congestion, this is ectasia. It's when you have this background with red spots, that's much more likely related to portal hypertension. So generally, when we approach this patient, again, as Wim said, about 5 to 10% of all chronic bleeding is in the small intestine. I think in cirrhosis, perhaps about 10% is from the small intestine. So we first look at patient, does this patient have cirrhosis or no cirrhosis? If they don't have cirrhosis, 40% are related to ectasia, then small bowel tumors. And nowadays, what we find most of all is in these left ventricular assist devices, they tend to have a lot of angiodysplasia bleeding. If it's a patient with cirrhosis and small intestinal bleeding, I'm generally considering 3 causes. Is this from portal hypertensive enteropathy? Is this from angiodysplasia? And is this from ectopic varices? Ectopic varices will be in the duodenum in cirrhosis, sites of surgery in cirrhosis like stomal varices, or elsewhere in the small intestine. Just one comment on the capsule. You know, if you look at the images of the capsule, it goes back and forth in the stomach and then jumps out of the stomach into the small intestine, and then essentially jumps out of the duodenum into the jejunum. So the duodenum and very proximal jejunum are not well seen on capsule endoscopy. So before we would do a capsule, we would do an extended upper endoscopy, that is a dedicated pediatric colonoscope. So we can look at the lesions. You often find lesions in the proximal jejunum. This can go about 50 centimeters, and we can also treat. Only if we don't see a lesion there, then we will go to a capsule.
Okay, so a note of caution about the proximal jejunum at the capsule. So that's really helpful. So according to you, Patrick, would you start in a patient bleeding, or at least with iron deficiency anemia, with endoscopy as the first line treatment?
Yeah. So Initially, these patients with chronic bleeding would have an upper endoscopy and a colonoscopy, and most often for all of us, it would be a patient referred to us. So we take a relook endoscopy, and typically the place where lesions are missed is in the proximal upper tract, so in the distal duodenum or jejunum. At colonoscopy, most people don't miss lesions. So if we are sure it was a good procedure done, then we will do an extended upper endoscopy. If we don't find anything there to treat, then we will go to the capsule.
Okay, so Wim, you are performing a lot of endoscopy, and practically speaking, what treatment are you using to treat this angiodysplasia?
First of all, maybe before I go into that, I would like to support the point of Patrick. It's really, I mean, this is also the approach we are taking, and it's really important to emphasize that about 80% of the angiodysplasias you will find in the duodenum and jejunum. So everyone thinks that these lesions are usually much deeper into the small bowel. It's only 20% that is in the ileum, where in fact you have the added value of the capsule. So before going to immediately to capsule, it's really imperative that you do a repeat upper GI endoscopy and colonoscopy. So that's really important. But before I choose my options,
we'll take a message there. We have a big take-home message from this EASL Studio episode.
No, but it's very important because usually everyone knows about the capsule, but everyone forgets about the endoscopy. So, so it is really important. I think before you go into therapy, you need to know where the lesion is. I mean, there are 4 items that define your approach. First of all, where is the lesion located? If it's in the ileum in your diagnostic approach, well, then you will need a dedicated scope, being an enteroscope. If it's in the duodenum or proximal jejunum, well, then maybe even with a colonoscopy, you could do the work. So that's the first question. Where is the lesion located? Secondly, what is the type? If you've diagnosed a flat, pale red angiodysplasia, I don't know, and I'm not convinced that this will probably be the culprit lesion. So, I mean, if you have active bleeding, well, then for sure you have a good hard argument to go for an intervention. Then the third one is, of course, whether this is the first presentation or recurrent presentation. Because if there was already endotherapy, you should realize that maybe your chances of success will be lower than the first approach. And fourthly, is the patient stable or unstable? Because if you are dealing with an unstable patient, then maybe you should consider other options, being angiographic, or even if CT with IV contrast to locate the bleeding, because then it's not going to be endoscopy. Or you are considering intraoperative endoscopy, which is also an option in very, very severe and extreme cases. But if you have an endotherapeutic approach, so this would be ideally a high lesion that is actively bleeding, preferably solitary, because if there are multiple, it's also usually not so easy. And usually what you do is go for thermal destruction of the vessel, and usually there APC is the preferred approach, or BiCAP, depending on your availability. But so APC is usually the preferred option. There are some serious
side effects. Are there side effects?
With APC? It's usually very limited because it's a very superficial coagulation. So the risk of perforation, which everyone fears, is usually not a big problem. With BiCAP, it could be. There have been some case reports also on non-thermal interventions like clips and even mini bands, but I don't have personal experience with them. I think these are usually not so easy to perform in a very difficult to maneuver area of the intestine. So usually it's APC, but I think we also should emphasize that endoscopy is usually not the only approach that you will have to utilize in these patients, because you can only guarantee, according to some meta-analysis, 80% of success at 2 years in patients, which means that you are still left with some patients that will not respond to your intervention and will probably need other therapies.
Yes, how many endoscopies are needed usually, Wim?
It depends on the extension of the lesion. I mean, if there are multiple, this can take you a longer first procedure. It can take several repeat procedures. So it depends on the extension of the lesions. And yeah, the most easy one is, of course, if there's only one, But if there are multiple and if they are spread along the small bowel and even deeper into the ileum, yeah, it makes things sometimes very difficult. So I must admit that the small bowel is still to be gained territory. So it's a bit like astronauts now going to the moon. So it's a new territory. So the small bowel is the same. So.
Okay. In the 20% of the cases that are difficult to treat, I think this is what we call refractory bleeding. And Patrick, I think you've got an interesting definition of this so-called refractory bleeding. Could you tell us a little bit more about your view?
Yeah, so Pierre-Emmanuel, I always like to discuss with the patient. It's a shared decision. And the question I ask myself is, are we winning? I ask the patient, are we winning? Okay, so somewhere, if I think endoscopic treatment is not working, I feel I'm losing. But for the patient, maybe that's okay. But let's take small bowel enteroscopy. It's not easy. There's the single balloon with the silicone balloon, and there's the double balloon, which is latex, which is a little better, but patients with latex allergy cannot have it. It has to be done under general anesthesia. It's a long procedure. So how many times can we ask the patient to come back? You know, patients get frustrated very quickly with multiple small bowel procedures. Upper endoscopy, little less. And so I always think refractory is a combination of patient frustration, my frustration, and then we'll move on to something else.
Thank you. I like this definition. So Wim mentioned the fact that endoscopy is often not the only therapeutic approach. So Virginia, would you like to share with us what are the possible therapies on top of endoscopy?
Well, I think that the patients that we are treated, they have portal hypertension. They can have vascular lesions due to portal hypertension, and they may also have angiodysplasia. So the management is quite complicated. Most of the data that we have, the studies did not include patients with cirrhosis, so what complicates things further for our patients. So I will start like step by step. I mean, like the non-invasive things, like putting the patient on iron, and sometimes we also need to transfuse the patient while we are doing endoscopy. Then the big question is like, well, if I'm not controlling the thing, I'm starting to get frustrated. As Patrick said, it's like what's next? No, and next is like, is the patient already on beta blockers, or can I decrease the portal pressure? Like thinking that maybe
it works, the beta blockers on angiodysplasia?
Data that we have like almost no data. The data that we have are from the 90s and not in this specific setting. But if you think that the patient may have also portal hypertension, maybe also related to the thing, it's not harmful. We know that beta blockers, they have like other beneficial effects. So why not starting with non-selective beta blockers if the patient does have clinically significant portal hypertension. So you can start with
beta blockers. What else?
Then probably you are not controlling the whole thing, and you would like to move to somatostatin analogs. And we have recent data coming from the Dutch group on octreotide. This is something that is an injection every 28 days. The data in this randomized clinical trial were encouraging. However, only 3% more or less of the patients included did have cirrhosis. So this is also something that we can try in our population. It's quite safe, and it's an injection every month. So
You're talking about portal hypertension. An easy way to treat portal hypertension is placing a TIPS. Is that working, a TIPS, in those patients with small intestinal angiodysplasia and bleeding related to this small intestinal angiodysplasia?
So again, like coming to the same thing as beta blockers. So if the cause is portal hypertension, you may control the thing with a TIPS, but if the cause is not portal hypertension related, TIPS won't be beneficial. We have no data. The only data that we have are very ancient data, and I would say looking at the changes in the mucosa after placing a TIPS in patients with bleeding, and it seems that TIPS can change the endoscopic findings, right? But not as a clinical endpoint. And I think if the patient is bleeding from a true malformation, a true angiodysplasia, then TIPS here won't help the patient probably.
In general, when the patient is bleeding, a way to stop bleeding, this is to give antifibrinolytic agents like tranexamic acid. Wim, do you have experience with that? Is that an option in patients with bleeding related to small intestinal angiodysplasia?
Can I just go back a second with Virginia? Because what would be a case where you would consider a TIPS in these patients, in your personal opinion? I know there are no data, and maybe there's no good answer, probably there is not. But do you ever had a patient where you thought, well, I will go for a TIPS because I'm convinced that this will work? Or is this an impossible question?
If I'm convinced, I would say no, but I will try to look for another indication because I'm not really convinced that a TIPS will be the solution for the patient. But if you have a patient in front of you with an ascites that is getting refractory or any other indication, maybe I would feel like more comfortable to, okay, let's try, let's see if it works, but not as a primary option, I would say.
I share your opinion because I've seen a patient where they put a TIPS elsewhere and he came with the post-shunt encephalopathy with us. So then it's a bit of a problem. So I would also not put in a TIPS just for the mere sake of these lesions in cirrhosis, at least. Okay, sorry for the interruption.
And also, no, and I think that this is a very important concept because sometimes, I mean, the patient is referred to you, it's bleeding and nobody knows what to do. Most of the time, the patient could be with other comorbidities, sometimes anticoagulants, sometimes is an old patient, fragile, so the risk of hepatic encephalopathy on top of that due to the other conditions is high. Then if you cannot stop the anticoagulation because it has like a major indication, it will complicate the things further. So, well, I think, things can get like very messy, very complicated,
And this is often older individuals too, which may complicate those options like transplant. So going back to tranexamic acid, do you use it, Wim, or not?
To be honest, yes, because this is the situation where you are getting frustrated, like Patrick already suggested. So I often use tranexamic acid for these patients because there is some old literature, and it's not because it's old that it's bad, because often if the literature is old, it's forgotten or neglected because it's already too old. But there is some data that these lesions go along with hyperfibrinolysis. So tranexamic acid would be a hypothesis worth pursuing. And okay, in some patients, it gives you at least a decreased transfusion policy, or at least you can get them off transfusion. They still need repeated iron transfusion, but for some patients, it might help. On the other hand, it's something which is very globally available. It's very cheap. In Belgium, it costs about €1.50 for a gram, so that's very cheap. I think in comparison to the options we still need to discuss. So, and yeah, okay, in terms of safety, there have been some suggestions on thrombosis, but these are anecdotal, and there is some literature in gynecology, in dentistry, where they used it in big or large size trials, where in fact the side effects of thrombosis, which are feared, are very minimal. So I would try it, but it's not a miracle drug. So it's at least one part of an option. At least,
particularly in patients without a history of thrombosis in general, for the reasons you mentioned. But in not so rare cases, everything of all what we mentioned does not work. So Patrick, in those refractory cases, how do you manage the patients? We saw data from your group about bevacizumab and also recent data on thalidomide. So I would really be interested in seeing how you proceed with such cases.
So when the patient has failed endoscopic treatment, usually the simplest and cheapest is oral contraceptives. Estrogen progesterone complications. They were initially used for hereditary hemorrhagic telangiectasia for nasal bleeds. We've actually had very good results with them. They're very cheap. Be careful. If it's a woman, if they've had breast cancer, we don't use it. If they've had coronary artery disease, we don't use it. In men, we warn them about gynecomastia. And the box comes as 28 tablets. There are 21 active and 7 dummy tablets. So we tell them to take it continuously, throw away the 7. And that's particularly important in women who are typically older, postmenopausal, because if they take the dummy pills, then they'll get withdrawal bleeding. So this is very cheap. Bevacizumab is next. So if you fail, because bevacizumab is more expensive, more difficult to get approval, we'll next go to bevacizumab. So estrogen progesterone failure, we say, let's go to a VEGF inhibitor. If we look into why we get these angiodysplasia, it is supposed to be in general hypoxemia causes VEGF stimulation, which causes this vascular sprout. So if you inhibit VEGF, this is likely to be helpful. So we have thalidomide and related lenalidomide, and we have bevacizumab and pazopanib. So those are the 4 that we have. We've never had good luck with thalidomide. You've seen the Shanghai study in November's issue of New England Journal. None of them had cirrhosis. And with 100 milligram, they did really well. We used up to 200. We cannot use it in women of childbearing age because of teratogenicity. But otherwise, they tend to get severe neuropathy. They get constipation. So we've never had good luck with thalidomide. So we use bevacizumab. First thing we check with bevacizumab is the patient going to have a procedure soon? Because it inhibits wound healing. So if a patient is at the top of a transplant list, we won't use it because we don't know when the patient has a transplant. If they've had a procedure, we like to wait about 4 to 6 weeks. So we like to wait 4 to 6 weeks after the last endoscopy. And anyway, it takes about 4 to 6 weeks to know if the endoscopic treatment has worked. So once we've decided to use it, if the patient has not had hypertension or coronary artery disease or peripheral artery disease, so bevacizumab should not be used in these patients. If they've not had it, doses 5 milligrams per kilogram intravenously, given very slowly over 90 minutes. If it's given very rapidly, patients get hypotension, flushing, they have vomiting, maybe wheezing too. So 5 milligrams per kilogram intravenously every 2.
Frequently?
Yeah. So we give it every 2 weeks for 6 doses. If they've done well, then we do a sort of maintenance every month for another 6 months. Remember, we've not treated the problem here. So recurrence is about 40%. So we tell patients you will require retreatment.
Okay. And after 1 year, what happens usually? You just continue these monthly doses, or you further increase the lapse between 2 injections?
Correct. So we stop after a year if they've not bled. But I told you 40% within the year, we will be retreating. And then we go back to the same thing again.
Okay, thank you very much. This is very precise and helpful. We mentioned a little bit liver transplantation, which is also an option that can, in some cases, be discussed. Virginia, do you want to tell us your view on liver transplantation in this very specific setting of refractory bleeding due to small intestinal angiodysplasia?
Well, I think that as all the therapies that we have been discussing before, probably not only for this reason you will go for liver transplant, but the patient having refractory bleeding and cirrhosis, they may have like other causes. Usually they do have advanced cirrhosis with other complications. So yeah, then the question is there, is like, can we go to liver transplant and would we solve the problem? I mean, we do not know, but if the patient is also bleeding due to portal hypertension and has other complications of portal hypertension, then we will go for liver transplant, right? But well, complicated decision to take, I would say.
Okay, thank you very much. We are already reaching the end of this EASL Studio episode. I would like to thank a lot our three experts, Virginia, Wim, Patrick. Tune in the next week for an episode in honor of the World Cholangiocarcinoma Day and the US Cholangiocarcinoma Awareness Month, during which our speakers will aim at raising awareness and promoting a deeper understanding of intrahepatic cholangiocarcinoma. Remember to become a member and join the EASL family. Goodbye.
Bye. Goodbye.
Bye-bye.